I'm David Adams. It's my great pleasure to welcome you to the 5th ATS Mitral Conclave.
Hi, I'm Dr. Randy Martin, and I'm really happy to be joined by Dr. Cliff Barlow. You know that name, that famous name. Cliff, thank you very much
Pleasure to
for
be
joining
here,
us.
Randy. Thank you.
So tell me about the famous name.
Well, I just gave a talk on it, and it's a great story, and it's a fun story, but it's a story of contribution. Essentially, my father, John Barlow, was a cardiologist, and working in South Africa, he ascertained that the late systolic murmur and non-ejection click came from the mitral valve. And then he ascertained that there was a syndrome of symptoms associated with this. But effectively, and that was Barlow's syndrome, arguably.
Right.
But Carpentier, the great French surgeon, was describing repair techniques, and when faced with what we call a Barlow valve, this myxomatous valve with excessive tissue, annular dilatation, long cords, it was a mouthful to describe, so he called it a Barlow valve.
Interesting.
But that was nothing that Barlow described.
So you become a cardiac surgeon. Why didn't you become a cardiologist?
Well, I have to explain to people that a cardiologist and a cardiac surgeon are two entirely different things. We work together, we cooperate, it's for the best. But I figured that in the field of cardiology, Barlow's had made enough of a contribution and I should do something else. But I love the heart and surgery, so put the two together, and that's why I did it.
That's great.
And I enjoy operating on them.
You sound like one of your former bosses and somebody I had a fun experience with at Stanford, Dr. Shumway, talking about cardiologists, cardiac surgeons, but he said it a little differently. But so tell me, is this whole concept of the Barlow's valve, the type of valve we have, and now we've got the malignant arrhythmia syndrome associated with it. I've been fortunate being in the early days of echo and have certainly looked at these. Where do you think our knowledge is and what would your father think about our knowledge now?
Well, it's the wonderful legacy of the past. So much that was described previously, but without the technology we have today. So my father, based on clinical examination, phonocardiography, cineangiocardiography, so many things that we don't use today. Yeah. But they set the foundations for our research.
Right.
And he recognized sudden death in so-called Barlow syndrome. He recognized the malignant arrhythmia syndrome, but he didn't understand it.
Right.
And it's fantastic listening to the talks today and all the groups involved in elucidating what the causes are and what we should do about it. So he would be delighted that there's ongoing research. But the name was never, the eponym was never hugely important to him. You just had to be precise about your definitions.
How did he treat patients that had this syndrome?
Well, he was a fantastic clinician.
Right.
Obsessional in terms of clinical examination. But in terms of treatment, he felt you had to identify exactly what the functional pathology was, which is why he thought the collaboration between surgeon and cardiologist was so important. Because it's only in identifying precisely what's wrong that you can then put it right.
Right.
That's understanding the functional anatomy.
But yeah, and he's obviously was right, and it's fortunate. I was trained in cardiology before a lot of the technology was there, so not as well trained as the English and the South Africans, but so I learned about stethoscopes and apex cardiograms and phonos. But if he had a patient then, what were the treatment options, the therapeutic options that he had?
Well, I think importantly, he recognized that the syndrome consisted of, predominantly in young women, was anxiety, palpitations, atypical chest pain.
Right.
So really reassurance in the first instance, and not calling it mitral valve prolapse if the valve was functionally normal, because prolapse is always abnormal. So if it's just billowing, just call it something else, a billowing valve. Beta blockers have a role.
Right.
Reassurance has a role. But there are times when you do get these malignant dysrhythmias, even in the absence of severe regurgitation, that surgery may be appropriate. But obviously timing and type of surgery. Without a doubt, mitral repair and good repair. And it's one of the most challenging repairs we do.
No, it really is. Let me ask you, as a cardiac surgeon who's lived in the valve space as well as by birthright and otherwise, where do you see surgical and transcatheter therapies going for mitral valve disease?
Well, the first thing is I think it's going to be a fascinating collaboration, and I think it's going to be a mutual development, and there's always going to be a role for each. But the explosion of different therapies through transcatheter are just going to come to fruition. There are going to be certain conditions that will be best treated with those therapies in certain patients. But other patients where with comorbidities, and if one wants a particular type of repair, because we must remember with the mitral repair, there are certain fundamentals that we aim to achieve on every occasion. Complete elimination of regurgitation,
Absolutely.
sure, but it must be long-lasting,
Durability.
must be associated without any gradient. And at the moment, the transcatheter therapies can't provide that, and that's what the patient needs.
No, you're exactly right, and it's something I've certainly argued about the durability and the therapeutic sort of cessation of mitral regurgitation is very important. If you had to project out 20 years in the future, what percentage of mitral regurgitation procedures you think will be done transcatheter versus pure surgical?
I think, and this was discussed extensively yesterday.
Yes, I know.
I think approximately 75% transcatheter, and I think approximately 25% surgical.
Right.
I think many of the surgical through some minimally invasive route. But I think that there's a huge untapped pool of patients who are currently not being treated by either.
Correct.
And I think essentially we'll probably, and surgeons will probably still be doing as many operations, it's just that more people will be treated. Because undoubtedly it's going to start becoming apparent that early treatment, early prevention of myocardial dilatation, myocardial fibrosis,
Atrial
ventricular
fib.
distension, etc., is what leads to a sort of durability in the 30-year outcome, not the 30-week outcome.
You're correct. I mean, earlier and appropriate diagnosis can lead to earlier and appropriate management. And I think you're exactly right. Well, Cliff, it's been great to meet you. Certainly have mentioned the name all these years. It's great, but of not your name, but the name.
Okay.
And I didn't mention Cliff Barlow, but it's really good to meet you, and thank you so much. And I'm thrilled that you're involved in cardiac surgery.
My pleasure, Andy.
Good.
Thank you.
Thank you, and thank you for joining us.